Okay, so back to our talk. Thank you everyone for coming today. We're hoping to discuss a very important topic and sometimes a very controversial topic. So we really appreciate you all being here. I'm going to go ahead and introduce myself and our panel. My name is Lauren Berninger. I am the Interim Director of Palliative Medicine here at Johns Hopkins. And I'm going to introduce each of our panelists here. We have Dr. Ivy Akid. She is our Associate Program Director for our Hospice and Palliative Medicine Fellowship and an inpatient palliative medicine doctor here at Johns Hopkins Hospital. We also have Miriam Hansen Fairchild. Miriam is one of our wonderful oncology chaplains. We also have Barb Hirsch. She is Senior Counsel for Johns Hopkins Medical Institutions. And we also have Naja Williams, who is one of our wonderful social workers from Johns Hopkins Oncology. So join me in thanking them for being panelists for us today. So these are our objectives. I want to first define medical aid in dying and distinguish this from voluntary active euthanasia. We're going to review the history of aid in dying in the United States. We're going to specifically talk about the legal status of aid in dying in Maryland and the District of Columbia. As you know, Johns Hopkins is present in both Maryland and the District of Columbia, which can present ethical and legal issues for us. We're going to discuss ethical issues relevant to the practice of MAID and current professional organization position statements on this. We're going to recognize spiritual distress in the setting of terminal illness and understand how different religious and spiritual beliefs may influence a person's end-of-life preferences. And then we're going to provide a general framework for responding to requests for hastened death in patients with terminal illness, and we'll do this with the help of our panel. So I'm going to fly through some slides as quickly as possible just to give you a little bit of context about what this is about. And we're going to start with a case. We're going to dissect this case with the help of our panel at the end. So this is our case. This is Ms. A. She is a 58-year-old engineering professor in excellent health who presents to a Maryland hospital after experiencing a seizure at a conference in Baltimore. History reveals several weeks of worsening headaches, which she initially attributed to work stressors, and imaging shows a large mass in the left temporal lobe with features suggestive of an aggressive glioblastoma. Ms. A is admitted to neurosurgery where the risks and benefits of surgical resection are discussed. Surgery is not curative and comes with a significant risk of neurologic injury given the extent and the location of the tumor. Oncology consultants discuss prognosis. Median survival is around 11 to 12 months, but many patients do live longer with newer therapies. There's a bit of uncertainty. Ms. A resides in Washington, D.C., and as an engineer and a professor, she strongly values her cognition and worries about a future living with brain cancer. She does not want to become dependent on others for her care. So Ms. A asks her oncology team, how can you help me get from point A to point B as quickly as possible? And the oncologist responds, can you tell me more about what you mean by that? And to that, Ms. A responds, I live in DC. Can you help me die before this disease gets worse? So let's talk about medical aid in dying. What is it? So medical aid in dying is a physician prescription of a lethal drug intended for a patient with full decision-making capacity to self-administer in the setting of a terminal illness with a prognosis of 6 months or less with the intent to end life. It's also known as physician-assisted suicide, physician aid in dying, physician-assisted death, or death with dignity. Prefer to take the word physician out of it. We can contrast this with voluntary active euthanasia, which is where a physician actively administers a lethal drug to end life at the request of the patient. This is not legal in the United States, and we're not going to talk much about the international community today. So why do patients request medical aid in dying? Studies show that it's largely about control. Patients wanting to control the circumstances of their death, worrying about future poor quality of life, worrying about future pain, future inability to care for oneself, right? And a study in 2019 in JAMA on trends in medical aid in dying in Oregon and Washington showed that the top 3 reasons for pursuing MAID included loss of autonomy, impaired quality of life, and fears of loss of dignity. So I'm going to, as quickly as possible, go through a brief history of aid in dying in the United States. In 1967, the first bill to legalize what they called physician-assisted suicide at the time was introduced in Florida. Ultimately, it did not pass. In 1976, we have the beginning of the right to die movement with many landmark cases, right? Starting with Karen Ann Quinlan, who many of you are familiar with. In 1980, you have the Hemlock Society formed. So the Hemlock Society was formed by British author Derek Humphrey and his wife Anne Humphrey and Gerald LaRue, and they co-founded this society in 1980. This is a direct reference to Socrates, right, and the ingestion of hemlock. And really, the purpose of this was to provide information to the dying and to provide supporting information about assisted death. So this was a very controversial article that was published in the New England Journal of Medicine in 1991 by Dr. Timothy Quill. Dr. Quill presented here the famous case of his patient Diane. He was a palliative physician at the University of Rochester. His patient Diane was diagnosed with acute leukemia. She did not want to go through chemotherapy, and she wanted instead to not prolong her life and to pass peacefully and quickly. So he directed her to the Hemlock Society, where she was able to review some information about assisted death. And she came back to him asking for a prescription of barbiturates for insomnia. He then gave her prescribed the medication. He told her what dose to take for insomnia and also told her what dose to take to end life, right? He didn't tell her, whether to go one way or the other. And then she eventually took the medication and passed away. And he wrote this article in the New England Journal of Medicine about his experience. And I encourage you all to read it. So charges were brought against him, but a grand jury declined to indict him. And the state medical board in New York actually allowed him to keep practicing. And they recommended that the subject be studied by an ethics panel. So that is Dr. Quill. In 1991, Derek Humphrey, who I mentioned before, actually publishes the New York Times bestseller Final Exit. And this is really a manual for patients who are interested in assisted dying. And you'll see on the left here, here's the cover of the book. And this is a page from the middle of the book that actually contains some cocktails for how one might proceed with this. That brings us to 1994. We find Oregon to be the first state to legalize what they called at the time physician aid in dying. It passed by voter referendum, but an injunction delayed the law's implementation. It ultimately passed in 1997. I'm sure many of you are familiar with Dr. Jack Kevorkian. He was a retired pathologist who believed that patients should be able to end their lives. He created the famous euthanasia machine. Later on in his career, he was found guilty of second-degree murder when he kind of crossed the line from physician aid in dying to active euthanasia, and that was with an ALS patient. His name was Thomas Uke. And so I think many of you probably remember this being covered in the news media pretty prominently back then. Brittany Maynard was also another very prominent person in aid in dying. So she was diagnosed with glioblastoma and moved from California to Oregon to take advantage of their state's death with dignity law. And she became a very strong advocate for MAID. She aligned with Compassion and Choices to create the Brittany Maynard Fund to advocate for medical aid in dying in other states. And she wrote a piece for CNN, My Right to Die at 21, which some of you may have read. So let's revisit the ethical debate. Let's go back to ancient Greece and the Hippocratic Oath, right? I will use treatment to help the sick according to my ability and judgment, but never with a view to injury or wrongdoing. Neither will I administer a poison to anyone when asked to do so, nor will I suggest such a course. Right? We know that Christian theology also plays quite a role in clinical ethics, even through today. St. Augustine viewed suicide as a violation of the commandment, thou shalt not kill. St. Thomas Aquinas, who's kind of the father of natural law theory and the doctrine of double effect, felt that suicide was contrary to self-love and God's gift of life, right? And the Roman Catholic Church would view this as a mortal sin. So we can review here very quickly the doctrine of double effect, also known as the principle of double effect. And the idea behind this is that you have an action the intent is a good effect. Sometimes there's a bad side effect, right? But your intent is always something good. And so the classic example is that you give someone a pain medication. The intention is to alleviate their pain and their suffering. Sometimes as a side effect, perhaps they have, a more hastened death, right? That's different than giving someone a drug with the intent to end life, right? Which they would probably consider a bad or an evil effect, right? And philosophers can dissect this, but this is the classic thinking under natural law theory. So all of this kind of plays into the ethical discussion on this. Whoops. So let's talk about autonomy. So autonomy is about respect for persons and their decisions. It's also about transparency. Should physicians openly discuss MAID as an option for patients? That's a really good question, right? And our panel can talk a little bit about that. Also, do patients have an absolute right to autonomous decisions in medicine, right? Beneficence and non-maleficence. Is medical aid in dying an act of beneficence? Is it giving patients a sense of control? Is it ending uncontrolled current or future suffering? What are the harms, though, to patients, to families, to society, and to the physician-patient relationship if medical aid in dying is legal, right? And what is the risk of coercion, and what are the risks to vulnerable groups? And then that brings us to justice. Who has access to MAID? Is access equitable, right? And are all patients equally informed of medical aid in dying as an option? So let's look at who's getting MAID, right? So the majority of patients are older. The majority are white. The majority have a college education and are medically insured. The majority have cancer. Second to that is a neurological illness, for example, a neurodegenerative condition like ALS. And the majority are also enrolled in hospice. And this is from a 2019 study from Oregon and Washington. So who pays for MAID? So there's a lot of insurance coverage challenges and high out-of-pocket costs for medications. And there's a ban on the federal use of funding for medical aid in dying. So, Medicare, Medicaid, which in some states is partially federally funded, TRICARE, federal hospitals, Veterans Affairs facilities, these patients are typically not getting medical aid in dying covered. As far as we know, it's not covered in the District of Columbia under Medicaid or Medicare as well. So, and Medicaid coverage we know depends on the state. So therefore it can be covered in some states and not in others. So in summary, again, the overwhelming majority of patients are Caucasian, highly educated, insured, and receiving hospice care. Mara Bookbinder wrote a really nice article really raising the question, we know that patients who already know about the laws are more educated, right? And so should we wait for patients to initiate a request for aid in dying? Or does that really create access gaps for people from less privileged backgrounds? I think Naja's going to talk to us a little bit about that too. Why do physicians conscientiously object to medical aid in dying? A study out of Canada showed that it's largely for emotional reasons, right? Emotions and psychological effects of prescribing a medication like this. There's also fear of legal repercussions, fear of social stigma, fear of death. So a study out of Colorado looked at physician attitudes and experiences with medical aid in dying in Colorado. It is legal there. 88% said they were willing to discuss it, but only 31% would be willing to be the attending, and only about 9% had served as an attending on a medical aid in dying case. 75% of those who did provide it felt that it was emotionally rewarding and professionally fulfilling. 75% found it time-consuming, and 46% found it ethically challenging. You might ask, what is the hospice position on medical aid in dying? This was a study of Washington state hospices and medical aid in dying. 39% actually use the terminology physician-assisted death or physician aid in dying. 16% actually use the word suicide in their terminology. And what's interesting is that 100% of these hospices had a religious affiliation. Is hospice allowed to be present at the time of ingestion of the drug? The majority of the hospices were not permitted to be there when the patient ingested the drug. Only a minority were allowed. Some were allowed presence after ingestion or prior to death. There's a lot of varying professional society positions on MAID. The American College of Physicians, which I'm a part of, is against medical aid in dying, very much opposed, as well as the American Medical Association. In favor includes the American Medical Student Association, the American Public Health Association, and the American Academy of Hospice and Palliative Medicine, which Dr. Kidd and I are a part of. They have a position of studied neutrality, and Dr. Kidd will talk to us about that. So I want to move on to the current legal status of medical aid in dying, and we will turn this over to Barb, who is going to talk to us about the DC Death with Dignity Act and how it applies to our providers.
Just adjust this. Can you guys hear me okay? Alrighty. And the button is enter or here?
Yeah, just the right.
This one?
The right arrow.
Okay, excellent. I think I'm the chosen senior counsel out of the whole team just because I sit in DC, oversee Sibley, Suburban, Grand Oaks Assisted Living, and the Renaissance. And when this first came into play and it got passed, the legal department was quick to say, we're not here to say yay or nay. We're here to support providers who may be interested in doing this. Since it is legal, we will help them navigate if we need to. So having said that, the history of it really started with DC Committee on Health within DC Council, and it has a little bit of a complicated process because, as you may or may not know, in the District of Columbia, most of the laws have to get federal congressional approval, right? Including the Death with Dignity law. So just in short, it gets introduced into the DC Council, then it has to go through the Committee on Health for 2 different readings, and then it pretty much gets to the mayor for her review. She signs off on it, and then it gets transmitted to Congress. So what happened the first time current President Trump was in office, it went through the whole process, and then it got referred over to Congress. There were 2 Republicans who entered different bills basically to get rid of it, and it never quite made it to the Senate. So it automatically became DC law. All right. This is important because there's lots of activity right now for the federal government to repeal it. So we may lose this in the District of Columbia. So there's 4 real main components to the law. The first one is that it really outlines the procedures and safeguards for the request for it, the prescribing of it, and for then the dispensing of it by a DC pharmacy. And all of them have requirements to report things directly into the DC government website when they do their part of it. The second thing is the dispensing of it. I'm going to just deviate here a little bit. We had experience with one particular pharmacy because the provider had called me, and this was years ago, basically saying the pharmacy won't dispense it. The pharmacist there today does not want anything to do with this. And so as a pharmacy assist at a pharmacy, it's the same as providers. The law may allow for it, the patient will qualify for it, but they are under no legal obligation to dispense the medication if they're the ones that are on duty that day. Effects on contracts, wills, and insurance policies. This is important because if somebody who's a DC resident qualified for it, they've got a good prescription for it, they got it dispensed to them. If they cross over to Maryland and take it there, because it's not legal in Maryland, it may very well be considered suicide for purposes of insurance policies and other related legal documents. And then immunity, anyone who participates in it legitimately, legally for the DC area resident and all, they have the same immunity as providers do for other parts of the DC law. Okay, so very straightforward here, and I think we already alluded to this earlier. It allows a person who's terminally ill to request the medication from a physician as long as that person is 18 years of age or older, has capacity, is a resident of DC, has a terminal disease, and they've gone through the steps required by the law to really request the medication, and they make the request for medicine voluntarily. If there's a granddaughter or a brother, sister, anybody who tries to monkey around and coerce grandpa to take the med, that is illegal under DC law. This we're not going to go through, but I'm just flashing up anybody who lives in DC. I don't know if anybody besides me but like to get a driver's license, to do anything, it's like complicated to deal with them presenting all these different documents. But interestingly, there is no requirement that you have to be a resident for any length of time, except what they're requiring typically you have to have received it within the last 60 days. So in theory, any one of you could move to the district with a month-to-month lease for purposes of establishing residency to be able to get your medication and self ingest it, and just show your month-to-month lease, show cell phone record that you changed your address, that's within the last 60 days, so on and so forth. Okay, so back to that definition from the law. Definition of terminal is described as an incurable, irreversible disease. It's been medically confirmed and will, within reasonable medical judgment, result in death within 6 months. One of the frequent questions is, well, what if the person's still living after 6 months? Is it all still legal? And the answer is yes. They'll have their little prescribed medication in their own residence, and they'll be able to ingest it. Little additional comment about residency. Back in the day, we had 3 different policies. We still have 3 policies today at Hopkins. One was for the hospital. In the past year, we worked with Dr. Doberman and Maria Savak to change it, to rename it instead of Sibley Hospital. It has to do with a DC resident who requests this, so that for JHCP and other providers who are also licensed in DC, if they're doing work in DC, it would include them. They don't have to be affiliated necessarily with Sibley. But patients at Sibley and admitted are not, we don't support them ingesting it on campus. The Renaissance is the senior living facility at Sibley, Hopkins entity. And if you're a long-term care patient, that's your home. So you would be able to ingest it there. But if you're there for short-term stay rehab, you would not be able to ingest it there, or not supported, right? Anybody could sneak it into their bag. Somebody brings it in from home because you got people around you, you ingest it. That's kind of my concern. Like one of these days, we're gonna have somebody just plop down in the lobby because they'll feel like there's people around them and they don't want to maybe die alone and be left in their apartment and nobody's gonna find them. And then finally, the assisted living, Grand Oaks, those residents there are able to ingest on campus. We have had a request, and then all the regs about locking up medication and not having people have the medication on them kind of came into play because our staff, nurses aides, nurses there do not get involved in this. Okay, sorry for that little diversion there. Steps to request. So this is the patient. They got to go online for DC Health and they've got to do an education module. And then to request it, they have to make 2 oral requests separated by at least 15 days. And then when they make their written request, there's a form online. Any one of you, if you just want to Google DC Death with Dignity, it will take you to DC government site with all of the requirements. There is a form, and that has to be filled out and completed at least 48 hours before the covered medication may be prescribed or dispensed in the presence of 2 witnesses. Okay, small print. This is just to show you all of these different links if you want to get familiar with the different forms. This is the form that gets filled out for that initial written request for medication. There's instructions. So just a couple of questions that we have gotten in the past, and we already covered this. No, a provider is not going to have action taken against them if they are not cooperating with a patient who requests it. In DC, our Hopkins entities, we do not keep a list. I couldn't tell you over the years who has written or not. I became familiar with one provider early on because he said, Barbara, I feel strongly about this. I want help, and I just want to be sure I want to do it right. People will field the calls. They'll transfer those calls to me. We've had people from a lot of different states say, who can you tell me will participate? And we say, sorry, we don't keep a list, right? I've had the Death with Dignity people, the compassionate caring people. They've wanted to come on campus, and Hopkins has taken the that we're not having people leave their pamphlets and all of that. That's where we are still today. All right, who can write a prescription? It's got to be a physician. No NPs, no PAs. It's got to be a physician. Sorry about the scattering on this. I did not catch this first time around when we converted it to Hopkins medicine slides, but within 30 days, the healthcare provider who wrote the prescription has to send to the Department of Health some information. And then if the patient actually ingests and they learn that they've died from it, they need to notify the Department of Health as soon as practical. Each year, Department of Health, they look at a sampling of these records that have been submitted, and then they annually publish a report. But I'm here to tell you, consistent with the rest of the District of Columbia processes, the most current report that's available is from 2022. Okay, so criminal action would include anyone who tampers with a request or coerces another person to request or ingest. We covered the immunity. Don't ingest in public. What that does is there can be a claim against their estate to recover costs and attorney fees for anything. So if you can imagine somebody comes into Sibley, maybe they're followed by the Oncology Center at Kimmel, Sibley, and they see their provider. They already have their prescription in hand from, maybe a month ago, and they decide to sit in our lobby and take it. Right? In theory, we legally can recover any removal of the body, whatever. Okay, not that important really. So where do they usually take the meds? In the privacy of their own home. This is from the 2022 report. It accounts for 11 people who had a prescription and some additional breakdown, but I don't want to get tied up with the legal. So I'm going to turn it back over to there you go.
So, all right. So let's get back to our case. The patient says, I live in DC. Can you help me die before this disease gets worse? And I want to turn this over to Dr. Akid right now. As a palliative doctor, I'm sure you may have encountered these requests before, both here in the state of Maryland and also probably during your training in California. How do you respond? How are you trained to respond?
Yes, thank you. Hello. Okay. Yes, thank you for that. For context, I did train in California where we honor the Maine Statute End of Life Option Act. And I certainly had to pivot my approach here. I actually created a mnemonic highlighting some of the most important things. I think the mnemonic I want to share with you, it's called aversion. If you have aversion to the discussion. The first and foremost thing, A, is align quickly, because I find that the first response in not just what you say, but also the tone that you take is very important. I have been kicked out of rooms in California because of this fact. It's really important to show that you take them very seriously and ultimately not to make the patient feel abandoned. Now, why is this happening and how can we align quickly? V is for vulnerability. We really need to acknowledge the vulnerability and courage that it takes for this request to be made. Consider that even just making the request, people already feel very strongly in terms of where they are in their disease. The emotions are absolutely already very much heightened. And this is something, of course, we all do, is first acknowledge the emotion while also recognizing our own emotions behind how we feel about MAID in and of itself. So just acknowledging that vulnerability and courage, I think, can really help steward that alignment. E is for explore. So explore why, right? Dr. Berninger mentioned a lot of the times it's about seeking that locus of control, grasping for autonomy. I remember a patient with breast cancer who carried the medication for about 15 years and had not used it. And I believe there's statistics out there, Barb can chime in, that a third of patients actually do not use the medication. So it really is about keeping that autonomy. R is for role. So it's really important that we ground ourselves in what is our role as providers. Our role is not to dissuade and it is not to convince, right? Our role is to really understand why they are making this request. And I think the ethical obligation is actually to help process the patient through their feelings, ethical obligation as providers. And then S is for stressors, so understanding what stressors there may be. Maybe there's financial stressors that we can help steward resources, support system as well. If maybe there's social pressures we don't know about. With that S and stressors and support, also identifying a healthcare decision maker, because in California, I think it was mandatory to have a healthcare decision maker. If a patient died prior to actually using the medication, it was the healthcare decisions maker responsibility to return the medication itself. So it's important to designate someone. And then I is for IDT, and I'm sure Miriam will speak more to this, but understanding what other disciplines can benefit. Let's assess spirituality, social work, of course. Mental health, is there a mental health component that needs to be addressed? So the referral process in California, so this is not under law, but our institutional policy was that the patient had to be evaluated as in like a psychological assessment by a mental health provider, but it is not like a legal mandate for that. But as providers, we should assess whether that is appropriate. And of course, assessing capacity. In this case, Miss A, given that she has GBM, she may lose capacity quite quickly, and the process can take some time. And so as providers, that is one of our roles. O is opportunities to reclaim control. So this has been really important in the approach for MAID for when the state does not allow for MAID. Because again, it's really about control. So what are other ways that we can offer choice? I absolutely take the opportunity to talk about code status, to talk about advanced care planning, so no escalation of care, that sort of thing. Of course, to talk about hospice as an option. Maybe they're not informed about that. And then sometimes I do talk about other alternatives like palliative sedation, as well as voluntary stopping eating and drinking, VSED, which is legal federally. And then N is nearest state, but really it's information providing resources that, may be available for them. Maybe they'd like to travel to a state where they can honor that if they feel strongly. But yeah, that is my approach.
Thanks so much, Ivy. I'm going to pose the next question to Naja. So, Naja, as you know, working here in oncology, we are often met with a lot of distrust from patients and family members. Can you comment on how medical aid in dying might affect that distrust?
I think, especially being here in Baltimore, we're very close to a community that struggles with trust of the medical profession, right? And so when you don't have that trust with your provider, how do you feel comfortable coming to them and saying how you're feeling and saying this is what you're thinking? And I think for some of the people that we're talking about, if they were presented with this option, they would probably wonder, well, you're just trying to write me off and you're not wanting to treat me and you don't think my life is worth it. When you look at the statistics on who's actually getting this offered to them, it's actually quite the opposite effect. And so it's really important that when we look at who this is being afforded to, you look at insurances aren't covering it. You look at the cost of the medication being over $1,000. Who can afford that, right? And so why is it that people who have means are being offered this chance to have control but I'm not, as someone who does not have means or for someone who is of a minority population. And I think that's also very important. And piggybacking off of what Ivy had mentioned too, I think it's also important when you are met with that first conversation is to not show judgment. Because think of how vulnerable that person had to be to come to you and say what they were thinking about and to be open. And so if you show judgment, they immediately will not come to you again with anything that they're questioning. And so I think that's important too.
Thanks so much, Naja. And then for Miriam, I'm wondering if you can shed a little bit of light on how people's religious or spiritual beliefs might influence their end-of-life preferences and specifically, their requests for medical aid in dying.
Yeah, so I think, right at the beginning, and as multiple folks have now said, we've been talking about a huge driver in this is what is it like for folks to find out they are losing control of their life, of their body? And what is it like to hear that after you receive a diagnosis and to know I'm in control of things now, but that has a very short window? I mean, our case, right? Okay, you have about a year. And as a chaplain, so much of my job is talking with folks about those existential fears and concerns around losing control. What does my life mean if I can't do X, Y, and Z? If I can't be with my kids as long as I envisioned? If I can't work my job? On and on. Of when I can't do those things, or when I'm anticipating having a very shortened time in which I'm going to do those things, what's the point? What meaning is left if I can't do those things anymore? And so as a chaplain, my job is less to look at what does your religion say, yay or nay, on is this appropriate, and instead to help you reconcile what you feel you as the patient need with whatever your religious institution might say, with whatever your family might say to you. And I think this is perhaps the key part from a chaplain perspective. There is research out there from the Pew Center that of the 16 major religions surveyed in the US, only 2 of those 16 actively would say we support a person's choice to end their life. And so the reality is, for anyone who does have a religious affiliation or belief, the vast majority of their religious support networks would not actually be supportive of that. And so then as a chaplain, regardless of my own religious perspective, how can I be supportive of them and be a person within the spiritual side of things who can support them as they're navigating making a choice that may directly contradict with what their religious teachings say? And so in doing that, it's a lot of exploring with them. How do you want to have control? What makes you comfortable in that? And whatever you end up deciding, can you be at peace with your decision, even if your religious group is not, even if your family is not?
Thanks so much. And for Barb, so many of us are licensed in both the District of Columbia and in the state of Maryland. Can you comment on physicians who are practicing in the District of Columbia who also have Maryland licenses? What are there legal protections for them if they choose to prescribe medical aid in dying?
Okay, I thought,
Can you hear me now? Oops.
can you hear me now? Okay,
Yeah.
it doesn't sound like it. I thought you were going to ask it in reverse, like for our patient in the study who presents, right?
I was going to ask you both ways.
Okay, I'll do that one first. That's the easiest one.
Yeah.
She presents right from the Baltimore conference. So she's taken locally here. She lives in DC, and that particular provider is taking her through her diagnosis. If that provider would happen to be licensed in DC, but gives the care in Maryland, they can't write for the prescription. It's got to be where they're really receiving the care.
Mhm.
So, a couple of us have tossed around different scenarios, and we still go back to that kind of endpoint, because really they would have to transfer the care, like oncology at Kimmel at Sibley, so that the care is being given in the District of Columbia. So it's a similar thing, like pregnancy termination and things. Just because it's legal in another state where you're licensed to practice doesn't give you legal authority under your scope of practice for the state that you're giving the care if it's not legal there. Does that
Yeah.
answer it? Okay.
And something else that I don't think we brought up earlier, I wasn't sure we would have enough time, but there are 2 states here where residency requirement is no longer a requirement. So Vermont was the first state back in 2023 to get rid of the residency requirement, which obviously can pose some challenges for neighboring states. And Oregon was number 2. So that is something. In our neighboring states, the District of Columbia and Delaware, where this recently became legal in 2025, in May of 2025, there is still a residency requirement. Yeah. Okay. Looking back at nausea, what mental health resources do we have for patients who we worry may be depressed or dealing with other mental health struggles that are leading to these requests? What resources do we have for them, and how do we approach them?
I think and speaking for oncology, we always have our oncology social work staff. We're very lucky that we have a robust support system within our department with our psych nurse liaison. We're very closely connected to our psych friends over in behavioral health, as well as our palliative folks, where we connect people to. Also making sure that they're connected to their community resources, whether that's local church community, local faith-based community, those types of things. We want to make sure that people are also connected with their PCP. That's the person that probably knows them the best, right? And making sure that that's a part of the conversation. I think it would be surprising for people to realize that people might have these conversations with their doctor and not have conversations with their families. And so you want to kind of explore that with them too, so that it's a safe space within their own family unit as well. I think it's important that people know that they're not in isolation in these feelings. When you are suffering from a chronic illness or a terminal illness, it can be very isolating. And so it's very important to connect them with people maybe who are also going through something similar, so that they can also feel that sense of community, and knowing that they're not outside the norm for what they're thinking. We often in social work get calls about someone crying during the diagnosis or during treatment, completely normal. We want people to have emotions. So I think it's important to recognize when it's something that needs a clinical intervention and something where it just needs processing and working through in a therapeutic note.
So I want to open up questions to the audience because I know you probably have a lot of questions, and we can't go around the room. Yeah. Go ahead. You can start. No, you, yeah. Okay.
And I actually have 2 people that I know that went through medically assisted death in Canada. And I guess the big question I have is, you have a lot of people that want to, if they can, may not to be to Canada, but travel to other countries to get made, specifically if they're looking at a physician ministry. Them in just.
Yeah, Canada is a little bit different, where I believe they do honor like a form of euthanasia, which is very different than a self-administered prescription medication. I think clinically it is tough to say because even the palliative cohort travel is a thing. It clinically they just may not be apt for it, whether it's physically or cognitively even. So I have not really seen in my experience, in my very little experience, people be able to travel. And that was the question, right? If you have seen that, and I have not seen that. I have not seen that. I will say that in California, I remember the referral process being, well, we need 2 oral consents and 1 written consent within the span, I think it had to be more than 15 days apart. In 2022, they changed that law to make it 48 hours apart. And so I think there's just a wide recognition that the process perhaps needs to be faster because of the circumstances that patients are in. I don't know if anyone else had.
Yeah.
Can you hear me? I was just going to add that I know of a patient in DC who was a Hopkins system patient right before the law got approved in DC, passed. She and her entire family went to Switzerland. And what the family shared with someone local to me basically said that they gave her some dark chocolate. She ate it, then she ingested, followed by some dark chocolate, and she went very peacefully. I have no idea what the combination was that they gave her or what her illness was, but, of course, had the resources, right, to travel to Switzerland, unlike most of our DC residents, I think.
Yeah, in the back.
Yeah, this is a great question. I think it's, it goes back to ethics. This is autonomy versus non-maleficence or beneficence. And, I do honor the autonomy. I do provide information and resources. Some of the resources available, there's a place called Barb can probably add to this, Compassion and Choices, as well as, and these are national organizations, the Death with Dignity National Center. These two places, they have websites, and I've actually printed this out for the patient, as well as printed information for the DC area because it's our closest state.
That accept this internal feel that we don't keep a list, and they get, and good or bad, wrong or right, we're just not there. So yeah, you can't call Sibley and say, who does this?
I imagine that's probably for protection for our providers as well, right? So it gives an idea of how volatile the issue is.
Patient.
Yeah, there's no prohibition against that anywhere in Maryland law or DC law or the Virginia law, now that we've got some practices out there. No federal law.
Ivor? Yeah.
Yeah, I think when it first got passed in, February of 2017, it really was kind of a shocker to everybody. Like, what do we do? What do we do? And people in the legal department, primarily me, I was talking to people from MedStar Health, and other entities to say, what are you all doing? And everybody was just so hush, hush, because honestly, the response from providers when I talked to medical staff meetings, med exec, it was like eggs thrown at me. And that's not a negative comment about the providers, but I was like tiptoeing around. I constantly was saying, we're here to support providers who want to exercise this end of life option, right, under DC law. So tell you the truth, we have not really revisited the discussion. I think we really would turn to our colleagues in palliative care and oncology and neurology where this might really come up and support it. The legal department's position always has been the law is here, so we're going to support our providers. Yeah.
I think it's worth also commenting just social culturally on what influences why we practice how we practice here. The state of Maryland actually was intended way back in the 1700s as a safe haven for English Catholics who were fleeing persecution in Anglican England. And so if we look at what has been our history as a state, as an entity, heavily influenced by Catholicism and the Catholic Church and the Catholic belief, we know we're largely diverse now, and that we have providers from all over the place, and that not everybody is Catholic as they may have been at one time in this area. But it's worth noting how years of one way of thinking influence a culture and influence how institutions have begun to operate. And so just considering why we may not be as public in that and why might other states have less reservation, I think we can't leave out just the cultural impacts of where we sit.
Piggybacking off of that, what I was going to say, this is a top down, right? Leadership, which is the federal government, does not recognize it. And so this is very much a state-based thing. Medicare will not pay for it. Any federal agency does not support it. So I think it's top down.
I saw a question over here. Yeah.
Me and spiritual departments. This is such an interesting topic, and it's making me think of when I used to work in adult and geriatric care, how many adults and children of adults would tell me, if my mom had known what this would look like, she would have chosen to leave earlier. The family didn't feel like they knew the full picture of how grave the prognosis was, the intensity of the suffering that was about to come. And I can speak from personal experience supporting my friend and her mother as her mother was dying, that there was a lot of reluctance from the provider to even open the discussion to palliative care or comfort care. And it was only their nurse who said, hey, this is probably what's going to happen in a week. Make your plans now. And they moved her to a level 3 DNR and she died 48 hours later. But my question is, how do you introduce medical aid in dying, or do you introduce medical aid in dying to families who might not know about it or might not be requesting this, but would benefit from knowing the picture, the impossible picture of the suffering that's awaiting their loved one if they don't?
So I think part of your question and part of your comment really speaks to an issue we have with truth telling as physicians, right? Talking to people about that anticipated trajectory and helping patients and families understand from the very beginning where this disease is going and what we're expecting. And I like the case that you just shared with us, we see this very, very, very often, that we're not talking about these issues until the very end. You know, I will say in my practice, I don't talk about medical aid in dying to my patients because it's not legal here in Maryland. And so I don't want to offer something that is not going to be available to them. You know, and I think Naja alluded to some of the other concerns about presenting that as well. If there's already mistrust and we're presenting it to people who are already a little bit skeptical of our care. But I want the rest of the panel to comment too.
No, that's exactly right. And I think even in states that do permit it and allow it, there are barriers. There's institutional barriers, there's cost barriers, right? Like not only certain commercial insurances will cover it. I know in California, the Medicaid portion, which is called Medi-Cal, does cover some of it. So it's just not available to everyone, even living in a state that does allow it.
But
I think also to speak to Lauren's point about honesty, right? It would be amazing to see those numbers if we were honest with people what their treatment and care would look like, on how many people would actually have more choices and autonomy and make this option a choice. I remember one of my first times being on rounds and seeing what some of our BMT patients go through and their complications. And I sort of made a joke that I would never do it. And my oncologist was like, what are you talking about? Everybody would do. No, not everybody would want to go through this. And so I think that that's also something we have to wrap our minds around, is people want more autonomy over their own health and their own bodies.
And I think early involvement of palliative medicine to talk about what's important to patients, talk about how we can manage symptoms along the disease trajectory is really important. And I think early hospice care, right, for patients who don't want to have life-sustaining treatments and want to focus on comfort and quality of life is really important. Yeah, Amy. It's the terminal illness, the terminal illness. The terminal illness,
Will be the terminal illness.
not phenobarbital overdose. Like it's going to be leukemia or glioblastoma.
And also the little tidbit, life insurance, people can still be eligible for it, even if they've used it.
So how? No,
No.
not if it's legal in that state. However, if you came with your medicine from D.C. over to Maryland and you took it, it would be listed probably as a suicide. You have to do it in the state where it's legal, and then it will always be the terminal diagnosis, which is, you know, cancer or ALS or whatever it is.
They know, right?
If they know,
Because they
yeah.
have family, it's gonna take
Yeah.
away the medicine.
Yeah.
Yeah.
Yeah, oh, Ben?
Either sympathizers after a kid or other felt that they needed to lay it out on the table, or did it then bring up the ethical issue or concern of persuading families and patients to explore?
I think it was definitely a gray area. That's a great point, Benjamin. Even in an institution that has a referral process, like a formal process set up, there were providers that did not feel comfortable. So, right, the provider is not ethically or morally obligated to prescribe, even if they can. There's no special license that is required for a physician to prescribe it. So, like, I'll just share, I myself am neutral about it. I'm not sure if I would, and I did not bring it up for with patients.
Ivor?
Yeah. I've asked government affairs for the Maryland side about that, and they say that they don't expect it to be a popular topic in this cycle of legislation.
It last came up, I think, in March of 2024, and it did not pass through. It didn't have approval. It didn't have a, yeah.
I want to add too, I'm wondering what the answer would be if any of you called an oncologist at Kimmel at Sibley and said, I'm interested in connecting my patient with someone. I mean, this is like since 2017. I haven't heard much from anyone having a legal question, but I know that I represented to you that it's pretty, yeah, no one knows. But in fact, there may be some practicing providers there that do refer patients to their colleagues who support it.
And sometimes patients themselves know by word of mouth from people who have had family members who have gone through this. I've had people tell me, I know I can't get this in Maryland, but I know how and where and who is going to give it to me in DC. So patients with resources often know. We can take one more question. I know we're over. Kim.
With the land, and so they were very supportive. What, I don't know percentage, or do you run into cases or have read about cases where this is what the patient wants, but the family is in opposition and what that looks like?
No, nothing other than what the law provides for, that if you try to intervene, go into their home, take away the medication, or vice versa, quite frankly, right? It's illegal, and I want to say it's categorized as a felony for intervening, interrupting and coercing or distracting from it.
Well, thank you all so very much for coming. Thank you to our panel. We appreciate the discussion.
Right.
Yeah.